Hi, I'm here with my colleague, Sue Morris. She's the New Brunswick Heart Center clinical nurse educator, and she is going to run us through inline suction for an intubated patient.
Okay, thank you, Vanessa. So I'm hanging out with my gentleman here. His name is Sim Jim. And when I think about the indications for suctioning, when I look at my ventilator and I record my hourly peak inspiratory pressure, sometimes people will call it my PIP, peak inspiratory pressure. The higher that goes, the bigger risk the patient is for barotrauma. And when I see my peak inspiratory pressure going up, one of the first things I should think of as a registered nurse is, does my patient need to be suctioned? Oftentimes it may be the patient is waking up and may need additional sedation, but the very first thing I should do is go and assess my patient. I may listen to his lungs to see if there is any coarser crackles or some actual mucus that is moving. And so I'm going to do some inline suction. So I'm going to tell my patient what I'm doing. So, hi Jim, it's Sue. I have to go down and clean your tube out of any phlegm that you might have. So this is going to make you cough and maybe take your breath away, but it will just be for a second and I'll be right here with you. So I've got my inline suction catheter connected to suction. I'm going to turn my suction on. It's at around 100. And then I have this device here. When I push it down, it should be in the locked position. So I can't push it down. So I'm going to turn it clockwise, and that will allow me to apply suction. So I am going to wear a pair of gloves. Don't have to be sterile, but a pair of gloves. And I am going to slide my catheter down my patient's tube. Going to do that gently until I meet resistance. And so I have met resistance. I don't want to push hard because what I'm going to do is cause trauma to the carina. So now I am going to apply my suction by pushing here. And I am going to pull the catheter out. What I do when I suction a patient is I hold my breath. When I need to breathe, my patient definitely needs to breathe, but we should not be holding the suction repeatedly. It should be for short intervals, such as 10-second intervals. Then I assess, potentially I have to go down a second time. So Jim, I have to go down your tube one more time here, sir. Sorry, I don't mean to make you cough. I meet resistance, I apply suction, and I pull it back. You can see up here, and I don't know if Vanessa can zoom in, but you can see a black line. This black line should be past where the ventilator attaches. So it should be in this window. When you pull this back, you should be able to see it on the right side of the green portion of the suction catheter. And then when you're all done, you are going to turn this again clockwise until it's in the locked position. Then you're going to take a peek at your patient's ventilator, and you're going to take a look at the peak inspiratory pressure and see that that pressure has come down. If it has not, then suctioning was not the reason for an increase in that respiratory pressure. So then you may have to assess sedation. Maybe the patient is biting on the tube and increasing the resistance. So assess the need for sedation. And then again, listen to your lungs. Has there been a change? You may have to call the respiratory therapist to get them to come up and do another assessment because your patient's lung capacity may be changing. The compliance and resistance may have changed, maybe due to adult respiratory distress syndrome, or your patient has gone into pulmonary edema. But there is a reason why the peak inspiratory pressure changes. Start with suction, go with sedation, and then maybe the issue is related to the lungs itself. So thank you for your attention, and we're just going to go over to this gentleman over here. He has a trach, and he also has an inline suction catheter. At the end here would be the tubing connected to your suction. And again, you would just suction this. Remember, the distance to the carina from the trachea is a lot less. So when you go in gingerly until you meet resistance. Then you are going, this is unlocked. So I would apply some pressure. I'm going to hold this with my gloved hand to make sure that I don't pull and put any traction on the trach itself. You can see the trach tube is nicely secured. I suction, I may cause the patient to cough. That's quite a normal response. Again, if I have more secretions, I'm going to tell my patient, Joe, I'm just going to go down and suction your tube one more time. I again hold my breath. As soon as I apply the suction, I hold my breath. There we go. We're all done, sir. Yeah, I'm just going to get you settled. Maybe we'll turn and position you now. And then when I'm all done, I turn it clockwise and it's in the locked position.